안녕하십니까. 나는 김성하입니다. Thank you very much for the kind introduction, Chairperson and the panelists. And very good to see you again in the distinct colleagues. My topic is to present experience with precalculus. We learned from the previous presenter, Sham, and the topic will be overlapped, but it's Japanese experience for a couple of years. My disclosures are described here. The Piccolo is compatible with a 4-French delivery catheter, specially designed for use in extremely low birth weight infants, those weighing 700 grams and above. According to the original guidelines, the device requires a PDA with a minimum diameter of 4 millimeter or less, and the length at least 3 millimeter. These specifications ensure that the device can safely and effectively close the PDA in these vulnerable patients. In 2016, as the Sham mentioned before, their team in Memphis identified the distinctive morphology in the PDA called type F, or the fetal type. This morphology is commonly seen in preterm infants within the first 1 or 2 months of life. The type F is characterized by a ductal length exceeding 10 millimeter, angling upwards across the 10 o'clock with a straight horizontal curve connecting to the pulmonary artery. This hockey stick configuration requires precise positioning in the device, in the shaft section of the stick for optimal outcomes. Sham gave us lectures in January 2020 at the JSHIC meeting in Okinawa. So all Japanese doctors learned from him. He demonstrated his personal sizing chart based on his more than 140 cases experiences, including a lot of premature babies at that point. Our JSA Society requires a stepwise approach to training with a progressive downsizing of patients' body weight to ensure the safety and skill development. We started treating 3 cases weighing 2 to 2.4 kilo, followed by 3 cases weighing 1 to 2 kilo. After completing these steps, we can treat premature infants weighing less than 1 kilo. This depicts the circumstances in a cath lab. We cut the center of the head side of the drape to make narrow U-shaped and covered with a transparent dressing. We prepared to visualize the skin color of the baby's head and trunk and check the transthoracic echo from the drape field. And we insert the pleuroid ideal sheath to the femoral vein with ultrasonic guidance. It has a straight standard 4 French interdiameter, but its thin wall makes its outer diameter equivalent to the other 3 French products. Let me show you the first case in a country less than 1 kilo. 18-year-old weighed 953 grams. On echo, it looks like type F. For crossing the PDA, we chose a 3-5 spring wire with a ball-shaped tip instead of a hydrophilic wire. But the recommended Holy wire is not available in Japan, so we used Asahi Intex Silverway wire. With the combination of 4 French thermoglide cath and a Silverway wire, every time we easily crossed the main pulmonary artery, PDA, and descending aorta. We injected 0.5 cc contrast manually from the tip of the glide cath while withdrawing, and we found a type F PDA with 2.5 millimeter at the pulmonary end. And according to the sizing chart, the size was less than 3 millimeter, so we selected the sleeve-through Piccolo. First, we retracted the distal end of the retention disc in the descending aorta, and then, using the nasogastric tube and the PI catheter placed the SVC as landmarks, we deployed the whole device inside the duct, as Sham mentioned before. We confirmed the Pacman sign, and we intentionally exposed the soft distal end of the delivery cable and applied a straight pushing force toward the aorta, taking care to prevent it from falling back out of the aorta, out of the pulmonary artery. The position of the device was perfect, and the residual shunt diminished 3 weeks after the procedure. The baby was weaned from the ventilator at 6 days of life and discharged from the prior NICU 50 days after the procedure. This is a list of potential complications in premature PDA closure identified by Dr. Sham. Perforation, LP stenosis, aortic stenosis, and device embolization or malposition, vessel injury and dissection, tricuspid regurgitation and residual shunt, and decreased function post-procedure, and pulmonary hypertension pre- and post-procedure. And this time, we'd like to focus on the three of these complications, which encountered in the early stage of our work: LPS stenosis, vessel dissection injury, and pulmonary hypertension. The second case involved a 24-day-old 1,130 gram infant with a suspected type F PDA. Using a 0.5 cc withdrawal injection, we observed a PDA with a central narrowing, measuring 3.3 millimeter at the PA end and 2.6 millimeter at the aortic end. According to this Dr. Sham's sizing chart, the choice between 4.2 and 5.2 device posed a difficult decision-making. Initially, we chose a 5.2 piccolo to prevent embolization in an early learning curve, which was 6.25 millimeter retention discs in diameter in both ends. However, it proved to be oversized. This chart, recalled from the anesthesia record, shows a sudden drop in oxygen saturation immediately after post-deployment, raising suspicion of PA occlusion. A quick echo check confirmed preserved blood flow in the RPA and the aortic arch, but the LP was completely blocked. We promptly switched to 4.2 piccolo, achieving a stable placement in an excellent outcome. The skin-to-skin procedure time was 39 seconds. The next case involves an infant born 31 weeks and 5 days with a birth weight of 1,614 grams, diagnosed with Down syndrome and persistent pulmonary hypertension of the newborn. Initial treatment with COX inhibitors proved ineffective. The echo showed a bidirectional shunt, a flat ventricular septum, and a left-to-right shunting at the atrial level. At the age of 15 days and 1,762 grams, we decided to bring him to our cath lab. With a 0.5 cc injection again, we achieved a full visualization of the PDA. Contrary to the initial echo assessment, the PDA measured 4.2 millimeter at the PA end and 5.1 millimeter at the aortic end, displaying a pronounced Type C configuration. Immediately after following the contrast injection, the patient had a significant saturation drop, which was identified as a pH crisis. Our anesthesiologist team administered inhaled oxygen, nitric oxide, and increased inotropes. Guided by the nasogastric tube and PI catheter as landmarks, we carefully deployed a 5.2 piccolo within the duct. Again, we carefully exposed the soft distal end of the delivery cable, applying gentle forward pressure towards the aorta to secure the placement while avoiding any dislodgement towards the pulmonary artery. The next day, the position remained perfect, with no leak, and the shunt between the ASD was reduced. Since the procedure, he was remained in excellent condition. In the following case, we still had a learning curve, the 30-day-old weighing 816 grams. Her PDA persisted in spite of more than 4 courses of COX inhibitor in the NICU. First, we had a difficult groin punctures. Then we advanced the assembly of a 4 French thermoglide cath and silver wire from the left side. But you notice something unusual here. It has accidentally entered from the left femoral artery. We decided to continue the procedure from the aortic side rather than removing the sheath. In the opposite way from the usual cases, we retracted the distal retention disc in the main pulmonary artery, and then we deployed the whole device inside the duct. We intentionally exposed the soft distal end of the delivery cable with gentle wiggling act, confirming the stability and releasing the device. Unfortunately, her left femoral artery was occluded, but fortunately, collateral soon developed, so the peripheral perfusion was adequate, so she was sent back to the local NICU. At her 1-year follow-up, the blood flow in her left leg remains comparable to normal. In preterm infants, device oversizing can frequently lead to obstruction of the pulmonary artery and aorta, as Dr. Wang and Dr. Sham mentioned before. However, device embolization is less common, given the lower blood pressure between the duct and the reduced blood flow across the duct, and conversely, in larger infants weighing 2 to 3 kilograms or more, or with a PDA diameter 2.5 or 3 millimeter or more, the PICO device can have a higher risk of embolization. This is an example of PICO device embolization, courtesy of my close friend, Dr. Takafuji from Showa University, Japan. This case involves a 3.5 kilo infant with a 3.2 millimeter type APDA, where the 5-4 PICO was undersized. Shortly after the placement, the device was embolized to the right pulmonary artery. Using a 7 millimeter gooseneck snare, they successfully grasped the body of the piccolo and smoothly retrieved it through a 4 French torque view delivery catheter. Followed by this case, Dr. Fuji and team conducted the bench tests with various settings to optimize the retrieval techniques. When grasping the main body or the connecting joint of the 5-4 piccolo with a 7 millimeter snare, you can retrieve it through a 4 French JR catheter. Grasping the distal marker band with the 7 millimeter snare also allow for easy retrieval for the 4 French torque view delivery catheter, and with some effort through the 4 French JR catheter. However, when you grasp the proximal end screw, you cannot retrieve it even through the 4 French torque view, larger than the 4 French JR catheter, due to being stuck at that point. Using a 10 millimeter snare, you can, which wire is thicker than the 7 millimeter one, provides a shallower grip. So if you grasp the distal marker band, you can retrieve it within the 4 French sheath rather than the catheter. Okay? But when you grasp the proximal end screw with the 10 millimeter snare, you will fail to retrieve it, even in the 4 French sheath. So in summary of my talk today, learning the implantation technique, appropriate device size, and postoperative management is important. Preparation for specific complications with these devices is crucial. For premature infants, PA and aortic stenosis is more common than device embolization. However, embolization usually occurs in the main pulmonary artery. Hemodynamics stability is typically maintained in these cases, allowing for more controlled and potentially straightforward retrieval. Thank you very much.